Medicare and Medicaid are programs that we, as Americans, hear a lot about. Every day it's Medicare this or Medicare that. Cut spending for Medicaid. We're all a little bit sick over the fight about healthcare. But here's what we, as future pharmacists, need to know about Medicare and Medicaid. Medicare was first introduced in 1935, but was not taken seriously until 30 years later in 1965, when Wilbur Mills, a leader in the House of Representatives, created a compromise for the three major proposals that were on the floor at the time. Those proposals were a compulsory health insurance program for the elderly, a voluntary insurance program for physician services, and a health insurance policy for the poor based on means, which would be administered by the states. Mills combined these first two proposals to create Medicare, and the third became Medicaid. These programs were signed into law as amendments to the Social Security Act by President Johnson in 1965 and came into effect the following year. Many people view the enactment of these plans as stopgap measures towards the enactment of a universal health care plan. Many believed the next president, frontrunners being Lyndon Johnson and Hubert Humphrey, would create a universal health care program. Instead, Richard Nixon was elected, and Medicare and Medicaid became permanent fixtures as progress halted on a universal health care plan until recently.
Medicare is made up of 4 parts, parts A through D. You are eligible for Medicare if you are at least 65 years of age, if you have received disability benefits from Social Security or from the Railroad Retirement Board, or if you have an end-stage renal disease which requires dialysis or transport. Medicare Part A is the hospital insurance. This covers hospital care, skilled nursing facilities, nursing home care, hospice, and home health services. 90 days of hospital stay is covered per benefit period, and 100 days of skilled nursing facility care is covered per benefit period. You must pay a deductible and a copay depending on your length of stay, as well as a blood deductible. Medicare Part B is the supplemental medical insurance. This covers doctor's office and hospital visits, nursing facilities and at-home services, x-rays, labs, dialysis, ambulance transport, vaccines, screenings for cancer or osteoporosis, diabetes monitoring, as well as some basic coverage for chiropractors, optometrists, podiatrists, and dental surgeons. Part B does not cover routine physicals, hearing aids, or routine dental care. You must pay a monthly premium and an annual deductible. Medicare Part C is the Medicare Advantage program. This provides increased options for beneficiaries like an HMO or a PPO. You can get prescription drug coverage with Part C, and Medicare Advantage beneficiaries save on average of $100 a month. Part D is the Medicare Prescription Drug Plan. Beneficiaries must pay an additional premium for this optional benefit. You can enroll in a prescription drug plan or a PDP by itself, or you can enroll in a Medicare Part C plan that includes a prescription drug plan. A freestanding prescription drug plan is usually more inexpensive and a better option. Medicare Part A is funded primarily from hospital insurance trust funds, which is financed by employee payroll taxes. Part A is also partially funded by beneficiary cost sharing. Part B is funded by a supplementary medical trust fund, cost sharing, and premiums.
In this chapter, we examine the case of a 67-year-old retired bank teller named Helen, who spent 10 days in the hospital and 4 weeks in a skilled nursing facility to treat life-threatening illnesses. She considered herself fortunate to be enrolled in Medicare in order to cover her health care expenses, since she herself could not given her low income. Helen was then surprised to learn that she needed to pay over $2,500 out of pocket for services Medicare did not cover. She doesn't understand why she owes so much when she was insured through Medicare. The majority of Americans who enroll in Medicare are unaware or confused about how it works. Like our patient Helen, many people believe that since they've paid into Medicare all of their life, it will cover all of their health care expenses, including skilled nursing. In order to be covered for services provided in a skilled nursing facility, a patient must be admitted for 3 days in the hospital. However, certain conditions must be met, one of which is a qualifying hospital stay, meaning that the patient must spend 3 days as an inpatient, not an outpatient. Helen had a 10-day hospital stay. However, seniors are often given an observation status rather than inpatient, in which case they are not eligible for Medicare reimbursement for skilled care, which they receive afterwards.
While Helen does have healthcare insurance through Medicare, not everything is covered under her policy, and she is still responsible for cost sharing. In actuality, Medicare pays less than half of the average beneficiary's medical expenses. Under Part A, she has to pay $840 for the inpatient hospital deductible. She would also be responsible for 8 daily co-payments for the skilled nursing facility care at $105 each day, totaling another $840. Therefore, her cost-sharing responsibility is $1,680 under Part A. Under Part B, she would have to pay a $100 deductible if she had not paid it earlier in the year for another healthcare service. In addition, she would have to pay for at least 20% of her physician charges. Under Part D, she has to pay in full for all of her prescriptions that were filled at her pharmacy, which could total hundreds of dollars alone. Therefore, during her hospital stay, it was very easy for Helen to accumulate a bill over $2,500, even though she has Medicare health insurance. A first option that Helen may want to research to prevent this from happening again is obtaining a Medicare Advantage insurance plan, which covers more services than Medicare alone. Another option that may have helped Helen to not have as many cost-sharing charges would be for her to obtain a Medigap insurance plan, which is the private plan that covers many charges not covered by Medicare. Once reviewing her own Medicare plan, Helen could select a Medigap plan that would cover the missing coverage of Medicare if she has the financial means to pay for that plan.
Medicaid is a federal state medical assistance program. There are many ways individuals that can be eligible for Medicaid. Being eligible can be described into 3 broad groups. It is important to note that Medicaid is a joint federal-state program, so some states can add flexibility to the criteria in their own way. The first group is the mandated categorically needy. This group includes families below the state-determined income limit, child living with a parent or relative that is deprived of parental support, individuals through the Social Security income program, pregnant women and children under the age of 6 below income limits, and all children under the age of 19 below the federal poverty level. These individuals cannot pay their medical bills because they are either below or under the state income limit. The second group is the optionally eligibility group. This group can only be determined for Medicare by the state itself. This group contains individuals that do not meet the mandated requirements, but do share some characteristics dealing with their income. If individuals do not qualify optionally eligibility group, then they must receive the same benefits as the ones in the mandated categorically needy group. The last group is the medically needy. This group is also controlled on the state level. This group exceeds the state income limit, but their medical expenses are extremely high. When individuals are qualified for Medicaid, providers must accept any amount Medicaid reimburses as payment. Medicaid is an optional program that the federal and state governments regulate. The federal government has a single agency in each state to control financing and administration. The state governments manage eligibility and their services. There are many benefits that are associated with Medicaid. Inpatient hospital service, prenatal care, physician services, x-rays, pediatric services, and family planning all fall under the mandated benefits. Optionally and medically needy groups mentioned before do have some specific benefits with their groups. Examples of optionally benefits include outpatient prescription drugs, physical therapy, and rehabilitation therapy. For the medically needy groups, examples of their benefits include delivery services, ambulance services, and home health services.
The next case is an illustration of how Medicaid eligibility is not uniform across all states. Charlotte is a single mother of 2 children, both under the age of 6, and her income is just 10% above federal poverty level for a family of 3. All 3 of them are insured under their state's Medicaid program. In another state, a married couple, Ed and Teresa, have an infant and are both working low-paying jobs with no health insurance offer from their employers. Their combined income brings them to the poverty level. Their child is insured by their state's Medicaid program, but they are not. In yet a different state, Jack is an agricultural worker whose income is less than half the poverty level, but he is not insured through his state's Medicaid program despite his low income. As a general trend across the United States, most uninsured Americans are those in low-income, working-class families. Last year, over 80% uninsured were in working-class families and 50% were below poverty level. Furthermore, more adults than children are uninsured. In 2014, a survey revealed that 48% of uninsured adults find coverage to be too expensive, 12% had barriers related to work, either they were unemployed or their employer doesn't offer health insurance, as is the case with Ed and Teresa, and 13% were told that they were not eligible because of their immigrant status.
Medicaid coverage is not uniform, but rather varies state by state and has minimal federal mandates. The federal government does provide guidelines for states in regards to categorizing which people have a higher need for Medicaid and should be covered, but still leave it to each state's discretion as to who they will cover. These categories are the categorically needy, optional eligibility groups, and medically needy groups. In this case, Charlotte and her 2 younger children were most likely covered because her state's Medicaid eligibility policy may be more lenient, and her situation falls into the categorically needy due to her children being so young. In the second situation of Ed and Teresa, their state's Medicaid eligibility policy may be stricter. Therefore, while their infant daughter falls under the categorically needy, they may not because they do not fall far enough below the federal poverty line to be considered for Medicaid benefits. The federal government does not make it mandatory to cover adults in this situation until their income is at least 185% below the federal poverty line. In the third situation, Jack may also live in a state that has strict Medicaid eligibility guidelines, and since he does not fall into a particular high priority category, he may have an even harder time qualifying for Medicaid. Overall, just because an individual has a low income does not mean that they will be qualified for Medicaid insurance in their state.
So what are the pitfalls from having Medicare and Medicaid? Because of the vast amount of people that are covered, 71% of the beneficiaries, there will be a need for a vast amount of money. Currently, there's $325 billion being spent on Medicare and Medicaid. 44% of those are for the disabled and needy, with 51% of those covered being children. However, they only account for 17% of the cost. 27% of the cost is actually the elderly. One of these pitfalls that was remedied was that of applying for a waiver. This was eliminated by the Balanced Budget Act of 1997. So what does the future look like? It's not too great. Because of the vast amount of people that are becoming elderly due to the baby boomers, there will be a great need for money in the future. It looks by 2023 there will be a total of $1 trillion aggregate being spent on Medicare and Medicaid. There will also be 5.8% of the GDP being spent on Medicare and Medicaid by 2030, and by 2080 it will nearly double to 10% of the GDP. That is a lot of money, and with every $9 out of $10 being spent on Medicare, Medicaid as it will not be supported, especially with more people being retired and less people being in the workforce. So what do we do as pharmacists? As pharmacists, we need to be able to be there and be supportive and expel our knowledge on those who do not know. There are many people in the Medigap that are either double dipping or do not know of the coverage that they have and they are not using it to the extent. This once stopgap that was the Medicare and Medicaid is now expected, and because of the amount of money that it will cost, it may not be there in the future.